Welcome to the September Sepsis Awareness Podcast for the Indiana Hospital Association, and I'm Rebecca Hancock, a Patient Safety and Quality Advisor at the Indiana Hospital Association. And with me today is Dr. Babar Khan, who is a research scientist at Regenstrief Institute and the Indiana University Center for Aging Research. Dr. Khan directs a critical care recovery center at Eskenazi Hospital, and he focuses on rehabilitation of ICU survivors and also delirium care. And we're privileged to have him share with us his current research and work for ICU survivors and their rehabilitation. Dr. Khan, please share with us your work.
Well, thank you for inviting me over to share our story and to give us an opportunity to showcase what we have been doing and what we are planning to achieve in the future. As you said in your introduction, I'm Babar Khan. I'm a pulmonary critical care physician at Indiana University, and I practice at Eskenazi Health Intensive Care Unit. So the story of our ICU survivorship work, especially sepsis survivorship work, started in 2011 when we initiated this clinic called the Critical Care Recovery Center, in short CCRC, specifically focusing on patients who were admitted to the intensive care unit who are on mechanical ventilation for 48 hours and or had delirium in the intensive care unit. Now, one of the things is most of the patients who are, when they are in the ICU on mechanical ventilation, they are admitted with sepsis, and a large number of them develop septic shock while they are in the ICU. There is also somewhat of a personal backstory associated with the development of this clinic, this Critical Care Recovery Center for our ICU survivors. And that story was a year and a half before we initiated the clinic in 2011. I was doing my pulmonary critical care fellowship at Indiana University, and I was privileged to be trained by amazing faculty, ICU staff who taught me how to manage patients in the intensive care unit. One of the things that was bothering us is that we would take care of patients in the ICU. Again, majority of them come in with infections, end up on mechanical ventilator, develop septic shock, being on medicines, antibiotics, deeply sedated. Sometimes we have to keep them comatose so they can work with the breathing machine, and we can manage their blood pressure and their heart condition. And then we were thinking that what was exactly happening to them once they get discharged from the ICU, because they end up going back to their primary care physicians. And at that time, the field of ICU survivorship was in its infancy. So we were kind of toying with the idea of how we can develop a follow-up system for patients getting out of the ICU and going back to the community. At the same time, one of my mentors, Dr. Praveen Mathur, who was a pulmonary critical care physician and who was my teacher during my fellowship, developed sepsis and septic shock and ended up getting admitted to the ICU and being on the breathing machine / mechanical ventilator. And then some of us took care of him while he was in the ICU. He ended up developing enough of respiratory failure that he required a tracheostomy. And then he survived the stay in the ICU and then was discharged to a rehab facility. And it took him at least 10 months to a year to get back and come to work part-time. So when this was happening, this story brought it real close to me on a personal level, that what I was thinking, we need to hurry up and develop a program, because when he gets to the community, there was no such program such as Critical Care Recovery Center available. Now, having said that, he had good insurance and he was in part of the health system, and so he was able to navigate some of the rehab process that needs to happen after his discharge. But one of his children, his daughter, she needs to actually come to Indiana and essentially work from Indiana and help navigate the healthcare system, even for his dad, who was part of the healthcare, and then help him go through the process of recovery and rehabilitation. So this was actually sort of the final push for me and our team to develop the Critical Care Recovery Center and to start the process of trying to create the recovery pathway for ICU survivors. So we went and we pushed for the clinic. We were really supported by the Eskenazi leadership, especially Dr. Lisa Harris, who told us that she would provide all the support and the supportive staff that I needed to start my survivor clinic. So the clinic opened up in 2011. In July 2011, first week, we started seeing patients in Wishart, which was the old hospital, and then the new hospital, Eskenazi Health. And my first patient that showed up in the clinic was a young gentleman who I took care of when I was a fellow a few months back in the ICU, and he was also a survivor of sepsis. The way the clinic was set up is everybody who comes to the clinic goes through a standardized assessment of their physical function, their neuropsychological status, including cognition, and then assessment for anxiety, depression, post-traumatic stress disorder. Also, medication reconciliation is performed so that we can take care of the medicines that they are not supposed to be on. We call this process the active de-prescribing process. And then we have care managers and social workers available in the clinic to help navigate the healthcare needs for the patient. So this process started in 2011. Ours was the first clinic in the United States, and now there are close to 11 clinics in the United States taking care of patients who are surviving sepsis and getting out from the hospital. One of the main things that come from the clinic is I personally see all the patients in the clinic. It's 1/2 day a week. And then the reason is when I talk to those patients in the clinic, it brings all those stories to us that we could not realize while they are in the ICU, that what are their experiences and how they feel, because we are very much focused on taking care of their other physiologic parameters, such as their breathing and their respiratory status, their blood pressure, and we are in sort of a survival mode to keep them alive. But once they come to the outpatient setting, that's where those experiences that really come home and culminate in the sort of disabilities or impairment that the sepsis survivors can develop when they get out of the ICU. So on an educational tone, patients who survive the ICU, they can suffer from memory problems or cognitive impairments. Up to 70% of patients who are on mechanical ventilation can develop cognitive problems, which includes attention problems, which include memory impairments, which also include executive function problems that can affect them getting back to their normal jobs that they used to do before getting admitted to the ICU. Up to 60–70% of the patient can have physical impairments, and 2/3 of them can have severe impairments. This can last up to years after getting discharged from the hospital. That's why a majority of the patients go to physical therapy and rehabilitation, but still a large number of them don't get the rehabilitation that they require getting out of the intensive care unit. The other thing that happens is up to 30% of the patient can suffer from depression, anxiety, and can have post-traumatic stress disorder, which are really, really difficult to treat. And also because of lack of awareness in the community, not all the primary care doctors screen patients for the psychological impairments that they can have getting out of the ICU. On another note, caregivers, informal caregivers of ICU survivors, they suffer from depression, they suffer from helplessness, and they also, some of our work, when we asked them as focus group, they said that they really don't understand that why when their loved ones were getting discharged, why the information on all these impairments is usually not provided at the time of discharge. So you can see this creates a big healthcare burden on the society and the community in general, as well as on the patients and their caregivers in particular. To put into perspective, about 5 million admissions happen to the ICU annually, with about 2 million of them have acute respiratory failure, and similar millions of sepsis patients getting admitted to the ICU. So if you look at that and then take into account the mortality of around 10 to 15% in the ICU, we have millions of ICU survivors getting into the community and suffering from cognitive impairments, behavioral and psychological impairments, and physical impairments, along with a higher caregiver burden for some of the caregivers giving up their jobs to take care of their loved ones. This translates into millions of dollars to the society, and hence the ICU Survivor Clinic, our critical care recovery center, was the initial step to start tackling this burden and to take care of patients who are getting out of the ICU. Now, what we have done, we have taken the critical care recovery center as the initial model, and then we have started another program, which is in its trial phase, called the Mobile Critical Care Recovery Program, in which instead of patients coming to my clinic, we have a nurse who has been trained to provide recovery processes at homes of the patients. She would go to the home of the patient and assess them at home, and then she would come back and talk to a multidisciplinary panel and then implement the recovery services at the homes of the patient. And we are looking at it to see how we can improve the quality of life of these ICU survivors at 1 year, at least at 1 year post-discharge, and possibly in the future longer. I believe that the combination of a clinic as a mothership and then the care coordinator services going into the community would be a way that we can tackle this post-intensive care syndrome, which the sepsis survivors suffer from when they get discharged from the ICU. And that way we can bring them to their pre-ICU level of functioning quickly, so they can become active members of the society after getting discharged from the ICU. And that way, that would be one way of approaching this problem and providing a new model of care that could be implemented all across the nation.
What I hear you saying is that when we listen to our patient stories, that really tends, and in your own experiences with patients, it really tends to drive home the need for improvement, and that the physician that you cared for really hit home and made you reach for something better for our patients. But understanding and listening to his story and his caregiver's stories greatly impacted you. Is that the case?
This is absolutely. I think what happened that as physicians, we kind of look at it from a different perspective, and somehow we have a tendency to step out of that a little bit. But once it happens to someone close to us, it hits home. And then the other important thing is, as ICU doctors, most of us only practice in the ICU, and we do not really get a chance to connect to the patients once they get discharged from the ICU. One of the lessons that I learned, that when you have patients coming back to you in the clinic, in the community, as a teacher or as one of our ICU patients, they teach us about how we can improve our ICU processes that can improve the care further along as they get discharged.
Lovely. That's very well stated. Can you touch on some of the interventions that you're considering that may be effective? I know you don't have your data completely analyzed or the studies done, but are you able to share what interventions you're testing?
Yes, perfectly. Actually, so the thing is that the trial results are obviously not here for the Mobile Critical Care Recovery Program, but we have 7 years of experience now with the Critical Care Recovery Center. The main focus of the recovery services through the clinic is in the form of a care coordinator. Now, that care coordinator could be a nurse or could be a social worker. Now, what we have done, we have trained that care coordinator into certain aspects. One is cognitive therapy, which is essentially brain exercises and training the patient and the family members how to do those brain exercises at home and the frequency of brain exercises. That's one. That's a cognitive therapy component that comes from the clinic. The other is doing exercises at home, the physical exercises, because after rehab, they get physical therapy for a little bit, and then the physical therapists leave them. So one of our ways is to train the caregivers on how to help the patient do certain sit-down exercises. So that's the physical therapy aspect. Now comes the big one, the depression, anxiety, post-traumatic stress disorder. And what we have done is we have trained our care coordinators into cognitive behavioral therapy and problem-solving therapy, and they do this active intervention very aggressively, 5 weeks of problem-solving therapy, 1 week contact with the care coordinator, either in person or over the phone, combine them plus minus with the medication that I can prescribe, and then also assessing them through that healthy aging brain care monitor, how their recovery trajectory is looking. So those are the three main focus, as you can see, on behavioral symptoms, cognitive symptoms, and physical symptoms. Additionally, we have a pharmacist that actively de-prescribe medications which have a negative brain function effect or that can negatively impact the recovery of the patient. So that's the fourth arm or fourth protocol that usually gets implemented at the critical care recovery center. And additionally, what we do, we try to do transitions of care because patients have multiple appointments with multiple subspecialists. So we try to organize those appointments in one time so that they don't have that many trips. And also, if there's relevant information, we provide that information to their primary care doctors and to their subspecialists so they can be part of the recovery process. So our clinic serves as a central connecting unit for all the specialists, helping navigating the transitions of care, de-prescribing of the medications, and those 3 and 4 big recovery processes focusing on these 3 aspects of recovery.
That is tremendous work that you're doing, Dr. Khan. And what I really appreciate is the reaching out of our clinical box where we focus on the biological needs of the patient and also include the psychosocial needs of the patient through the social worker and nurse care coordinators that you've implemented. I think it's a great leap for us in healthcare to understand that what we do may take care of the biological needs, but the psychosocial needs, which affect the biological needs of the patient, are integral to that recovery period. And I think that the work that you're doing is exciting, is really going to improve care for the sepsis survivors as we continue to improve our mortality rates related to sepsis. So I thank you for sharing your work and look forward to hearing results and publications to come. Thank you, Dr. Khan.
Yeah, thank you.